I would like to introduce Dr. Gwen Clarke. So Dr. Clarke is a hematopathologist with Island Health in Victoria, BC. Her academic interests include immunohematology and perinatal transfusion medicine, as well as quality assurance in lab medicine. She is the Secretary General for the ISBT and past president of the CSTM. She also has an interest in undergrad and postgraduate medical education, has served on the examination board for HemePath for the Royal College, and is a former program director for the residency training program. She is also currently working on the development of the Specialist in Transfusion Medicine Transfusion Science program, which is an advanced training program for medical technologists at the University of Alberta. So I'm going to let Dr. Clarke take it away, talking to us about strategies for staff shortages.
Hi, everybody. I accidentally went one slide ahead, but I won't go back. Nice to be here. And I guess one of my acknowledgements just before I get onto this slide is that I have given this talk a couple of times before at the last two ISBT meetings. So clearly staff shortages are a hot topic, not just in BC and in Canada, but all around the world. I have no conflicts of interest with respect to this presentation, and I really do need to acknowledge my colleague and the TM lead for Island Health, Jennifer Duncan, who has generously shared lots of her great ideas with me, as well as no small shortage of pictures in this presentation. So, I'm not sure. There we go. So my objectives really are pretty broadly to just convey some practical ideas about how to cope with fewer people doing more work, something that I think all of us are dealing with to one degree or another in one or more of our laboratories, and something which I think we need to acknowledge is probably going to get worse before it gets better. So, you know, nothing very high level or groundbreaking here, but like I say, just some practical ideas that I've tried to organize into a framework that we can all chip away at piece by piece. On the right are sort of the sections of the talk that we'll go through. So I won't go over them now, but we'll go through these areas. So the first thing is make a plan. I think as blood bankers, probably most of us are planners, and if these shortages are going to happen anyway, it's probably best to go into them with an idea of how we might respond. And there's lots of aspects to this planning. So to start with, we should be planning for recruitment and retention, because we know that even if our staffing complement is full today, that may not be true in 6 months or a year's time. So we really need an ongoing plan for recruitment and retention. And we need to make the process of hiring people smooth. So planning for interviews and hiring so that when you do post a position and people apply for it, that you can do that hiring, that interview and that hiring as smoothly as possible. Make sure that you don't have a long lag time between your posting and hiring of new people that might apply for your job. And then, of course, look at your staffing complement and try and plan ahead for succession planning. When retirements are looming, it's good to be proactive about when you're going to post for that job and who you might recruit into that position, either from your own workforce or where you might advertise. What I'm going to spend a little bit more time on, though, is talking about planning for how to work when staff shortages actually occur. So now the shortage is upon you. You don't have as many people as you think would be ideal in your laboratory. What can you do about that? And then, as importantly, probably planning for how to communicate that shortage to others in the community that you serve. So what are you going to tell ICU and Emerge about the availability of your blood bank staff? How are you going to do that? Good to think about that in advance of the crisis actually occurring. So a couple of things came together. Jennifer was working on this idea of a plan, and I thought, what a great idea. She really took what we've all been working on for many years in transfusion medicine, the blood shortages plan, and adapted it to contingency plan for management of technologist shortages, which I thought was brilliant. And as with many brilliant ideas, when we arrived at CSTM last year in 2023, it turned out there was actually a workshop on this where Anne-Sophie Lemay and others had talked about the similar thing, developing a technologist shortage plan and how to transform blood shortages plan into technologist shortages plan. So good idea to use a framework that we're all familiar with and have used, and think about how to apply that to a different kind of shortage. So on the right is sort of a table of contents of a blood shortages plan that most of you are probably familiar with. Thinking about the transfusion lab and what we actually do, thinking about a contingency, what are the assumptions and as part of that contingency, and then how could you structure it to address different levels of severity of your shortage in the green, amber, and red phases. and then some specific details about what you would do in each of these stages. So it really provides a very nice outline for how to think about technologist shortages. Brilliant idea. Not my idea, brilliant idea to Jennifer and the folks at CSTM workshop last year that put this together. So the first thing, of course, is you have to think about what's ideal. What's the best case scenario with your optimal staffing, and how do things work when your worker complement is completely full? And then you have to also organize around the degree of shortage. So obviously the things you're going to do are different if you're short for one shift versus if you're going to be short for months and months. And then you want to be quite specific about outlining what are your actions going to be at each stage. And then when it happens, it's not quite as much of a disaster because at least you have a plan in place. And ideally, maybe you've already communicated some of the steps that you're going to work through with the clinical team so that they're also aware of what will happen. The second thing you can do is organize and optimize so that those that are currently working can do so as effectively and efficiently as possible, and so that people that come in either as new staff or maybe filling in from another organization or a hospital down the road that you're affiliated with can work there because things are organized in a way that is easy to understand. So a well-lighted space with room to work, workstations equipped with everything that you need so you're not casting about for what you need to actually do the antibody investigation, labeled storage areas, and a regular process to replenish whatever's missing. Nothing worse than being in a new place and having no idea where you keep the paper clips. So think about those things as you organize the space, and it will also make the workplace better for the individuals that are already working there. These are just some examples. Here's a beautiful, clean workspace. Some of the people on this call will probably recognize, and well-labeled containers showing exactly what units of blood are where. That's the kind of thing that every laboratory aspires to, for sure. Rearrange the furniture if you need to ensure that your workflow is optimal and efficient. And consider something called human factors, which I'll go into, that will, the idea being, try and make it easy to choose the right thing to do so that the next step is obvious based on the way that your workspace is laid out. Many of you will have seen and maybe worked on something like this spaghetti diagram in the past, and this is just a technique to really look at the way that you've arranged your laboratory to make sure that the steps that you're taking to do that task are well organized, that you're not going completely from one end of the room to the other in order to do the 2 or 3 steps in your task. And you can evaluate this by actually drawing this out. Pick a task, a type and screen, and draw out where the person doing that testing would have to walk as they went through the steps of gathering the equipment and doing the test and entering the results. And maybe it turns out that you have your computers in the wrong place, or maybe it turns out that your reagents are in a fridge that's way too far away from where you're actually doing the task. So to the extent that you can, and I know laboratories are often pretty crunched for space, but to the extent that you can, try and organize things in a logical way. And you can do that by actually drawing this out. It's kind of fun to do this. I've done it in a couple of labs for just, as often when we get a new piece of equipment, it's a good time to think about reorganizing. And sometimes that's really an effective way to just make the workflow more efficient for everybody that's in that room, which is good whether you're short of staff or not. So what about this human factors that I talked about? So the definition from Google and company is human factors are the biases and attributes that affect individual performance. And so human factors engineering is an idea of designing a system to take into account human behaviors and biases. And I've just shown a simple example here where we have a fridge that includes both unmatched and matched blood. And so making sure that the shelf that contains the unmatched is very clearly and obviously labeled. So that a person that's thinking about 1,000 other things when they go into this fridge are sort of automatically directed toward the right units of blood if they're using blood in an emergency situation. That's one example. And there's many others that you can think of that sort of drive you to do the right thing, document in the right place. A good place to think that I always think about human factors is when I look at really terrible forms where you're filling out something at the top and then you're filling out something at the bottom. So a human factors engineered form would take into account the order that which you're going to fill this out, or the order of information that you're going to have at hand, and make it so that it's completely streamlined. So you can think about this with respect to everything that you do, but it's particularly important when you're dealing with staff that might be insufficient in number and are doing multiple things at once. Another thing that you can do is just review what you do. Consider everything. Look at your test menu, your requisitions, and your ordering. And are there tests that you're doing that you don't actually need to do? You can work with clinical teams to maintain the most impactful testing or to evaluate things that are really time-consuming and cumbersome and see whether A, you can adjust the way that they're done, or B, whether you need to do them at all. Certainly in the context of your contingency plan, there may be some tests that are formally delayed or even stopped as part of the blood shortages plan. So there might be some things that you're doing that, if you're down 3 staff members, this is just no longer part of your menu. So, an example that I commonly use would be a Doneth Landsteiner. Most of us do that very rarely and might be able to get away without having that on our books at all. And it might be something that you just wouldn't do if you were very short of people. Optimizing the inventory. So can you limit or reorganize the number of shipments from the supplier or the timing of the shipments so that they coincide with optimal staffing and that you're not trying to inventory enter blood at a time when you have a single staff member working? So think about everything. What is the work that you do in your laboratory, and how can you rearrange either the testing you're doing or even reduce the amount of testing that you're doing in order to ensure that you're just providing the testing that is really absolutely required. You can actually look at the requisition in detail and simplify your test menu. If you think about it, a hospital transfusion service does a relatively small number of tests. Really we're interested in knowing people's blood group and their antibody screen results in order to be able to provide blood for them when they need it. So that's a pretty short list. Many of our laboratories at hospitals where pregnant women are cared for would also have some testing around Rh immune globulin eligibility or management of pregnancies with antibodies. But it's a short list. And so if there are a whole bunch of extraneous things on your test requests, think about whether you need to do those and whether they could be done in a different way or with a partner. And then next, now that you've looked at what the work is that you're doing, look at your workflow. What is the process of doing that work? What kind of shape are your procedures in, and what do your forms and worksheets look like? Can you optimize them to make it easier for people to do their jobs? This is an example of a time when we were getting a new piece of equipment and we looked through our type and screen procedure and really just modified the process, both to fit our new piece of equipment, but also just to increase the logic of the procedure. And the bottom picture is my favorite. It shows the stack of procedures that we went from to the stack of procedures that we ended up with. And that's just a lot easier for anybody to work with, let alone a small number of staff. It's also a lot fewer procedures to maintain. So really think about those process steps and evaluate whether you could rejig what you're doing. We tend to be, in laboratories, we tend to do what we've always done. And so sometimes a staff shortage is an opportunity to think about, can we shake up the way that we do things? And is there a more efficient way to do so? There's lots of tools to help you do this. One place that I found when I was working on this talk and with some of my work at ISBT is actually the WHO, who have really great tools on procedure and process development that I never would have thought to go to. I've included a link on the slide here for that section. And there's process mapping. I'm the kind of person that likes to be able to look at a map like this and say, okay, what's the first thing? This test, and if the test of this result of this test goes in this direction, then I do this. And then each of these little boxes may be part of a specific procedure. Procedure documents, sometimes they're mandated by your region, or the particular style of the procedure is a requirement of your document control software, but to the extent possible, have a look at those procedures and make sure that they make sense. So again, the WHO has some recommendations about that, about the classifications of procedures. So divided into tasks, safety, and equipment, for example, that might have slightly different formats between them. So there are resources out there, and if yours aren't great, if your technologists if as a technologist you find that you're flipping back and forth in your procedures, maybe the problem is not the content, but really the format. And it may be worth thinking about how you could reorganize what you put in that procedure or the way that you display it. What about audits? So we're familiar with audits from the DAP, for example, or Health Canada, as really evaluating whether we're conforming to standards. But the other way to think about audits is to have that outside set of eyes that might help to reveal areas for improvement. So not strictly about improvement with respect to conformance to standards, but improvement with respect to efficiency. And often that outside set of eyes is really helpful that way. That's one reason actually why I like to participate as an auditor. not so much to evaluate how that lab is doing vis-a-vis standards, but to think about, oh, look at the way they do this test. That's a great idea that I'm going to bring back to my own lab. So I encourage those of you that are working in laboratories to consider participating in laboratory audits, because you really do bring home this outside view. And it's always useful to have an internal audit. Maybe people from the lab down the street could come and have a look at your lab with a view to efficiency, not with a view to standards compliance. And you could do the same for them. That outside review, that extra set of eyes, is often really revealing. And then the right task, the right skills, the right time. We're not always great at this in clinical laboratories. I think in a time where we're really short of technologists, we want to ensure that those that are doing the work have the skills that they need. So obviously there are specific competencies for specific tasks, but you also want to consider who else is out there that could do some of the tasks in your lab. So is there an opportunity for trainees to do some work? Could you use lab assistants or clerical staff to do tasks that are not technical? And there's lots of examples for this. So there are laboratories where the phones are answered by clerical staff that triage those calls to the right lab area, avoiding having technologists always interrupted by picking up phones. Of course, all of us probably have experience with phlebotomists who really are trained on the job to do that task, freeing up technologists from doing those roles. And students may assist with tasks and undertake projects, especially method development or validation studies with supervision, and really provide a really important extra pair of hands. At the U of A, for many years, we participated in the Med Lab Science fourth year capping projects. And these have been just a wealth of both research and practical data for our laboratory. So every year there's 1 or 2 students that work in the lab and undertake some sort of a project. This is Sarah, who happened to be completing her project at the time that I was working on this talk. And on the right is sort of her testimonial about what a great experience it was for her. It also exposed the TM lab staff to her and ended up in her getting a job. But from the lab's perspective, students can do work related to utilization review, which might ultimately reduce unnecessary testing. They can do test optimization work. Should we do things this way or that way? They can do that kind of comparison for you. They may be able to do some SOP updates. And of course, they might get to really like you, and then you could hire them and mitigate your staff shortage. So I think greater engagement with our training areas is a great idea. We tend to think, of, oh, we're so busy, we can't possibly take on a student, but there's a lot of benefits to having students in your lab. What about sharing the load more widely? So I think we tend to work just in our silos, maybe especially in transfusion medicine. We think of ourselves as a little different from other lab areas. But I think the idea, as we reduce the number of staff across all of our laboratories, of sharing some staff or lab assistants that move among 2 or more departments is a really good idea. There are examples of staff in some labs on so-called modified work duties that can't do their standard technologist tasks, but maybe could still answer phones and call critical values. So they are using their technologist knowledge, but they're also easing the burden amongst people doing the active testing. You could share an SOP writer amongst several departments. You could identify SOPs and policies from published guidance and modify them for your local use rather than starting from scratch. You can ask for SOPs from similar labs. And you can even share the work. Could you refer tests that are rarely done to one laboratory in your area, more of a hub and spoke model? I know a lot of us do that already, but I think that there's probably some opportunity to do that even more. Within a hospital, there's maybe other departments that can assist. I think we're in a general staffing crisis in healthcare, so this isn't always possible, but is it possible for pharmacy to distribute or reconstitute blood products? For those of you that are doing a lot of reconstituting in your blood bank, can you move that on when the product goes out? Can they reconstitute it at the bedside as they would with medications? And can you establish a development area or team that could support things like validations for all areas of your lab instead of just your own area? Does a blood bank analyzer have to be validated by a blood bank tech, or could we share that kind of role with other areas in the laboratory? So I think a lot more collaborative thinking would go a ways to reducing the amount of staff that we need. And then what about blood components themselves? So can some dispensing and documentation by clinical staff happen when lab staff are not available? Rural sites have been doing this for years, and there are safe ways to have unmatched blood available to clinical staff, even if there isn't a technologist. You can prepare issue-ready unmatched red cells with accompanying logbooks for documentation, using your human factors thinking to make sure that the documentation occurs in the way that you want to. And maybe you could even issue coagulation products under, maybe in a conversation between the clinical team and the transfusion medicine doc on call, you could agree that fibrinogen or PCC were appropriate for that clinical setting, and those could be ready to go, again, with a logbook in hand. So those are all really just some ideas about what you could do in a hospital. And then, of course, there's also the regional kind of collaboration that we do and that we could do more of. Hospital labs from adjacent communities or regions, sharing policies and procedures, dividing the workload to develop those, maybe even sharing staff to provide cross coverage. We tend to run into issues related to unions and when we try and share overly much, but there is, of course, there's a lot of regionalization already, and sharing staff across facilities is feasible in some places, and maybe it will have to be more feasible in other places in the future. And then lastly, when things are really empty in your laboratory, there needs to be, this is where we come back to the plan, there needs to be a plan in place to divert patients to an alternate location if you really can't run your lab at all. So that's where we come back full circle to that planning step. And then to just touch on the future, I think we really are going to have to depend more and more on automating and interfacing. Wherever we can take hands off a task, we can use those hands for tasks that really need to be done by a human being. So we want to do things like minimize paper documentation wherever possible, utilizing our lab information systems and middleware to the greatest extent possible. We want to make sure that our ordering and our resulting and reporting are all linked so that we're not doing several manual steps between all of those stages of the pre-analytic, analytic, and post-analytic processes. We want to automate our serologic testing to the largest extent possible. Of course, a big thing is auto-dispensing fridges, which are a great idea in a lab that you can't staff 24/7. We want to invest in equipment and techniques that are less hands-on or time-sensitive. So a lot of us are using gel or solid phase techniques, and that is one example of that. Automated phenotyping, automated initial panel evaluation are all either here or coming to us soon. And an online interface with a reference lab that can help interpret those panels when you have a site that doesn't have dedicated blood bank technologists is also a real possibility. And then from the supplier side, as more and more of our units have phenotyping on them, that adjusts the work that we have to do in hospitals to find compatible units of blood. So these are all on the near horizon and are things that we should be eagerly adopting because we're going to need them all in order to effectively work in the context of fewer people in the building. So just to summarize all of that, you want to start by exploring your environment and your processes and just look for opportunities to improve efficiency. You want to work with others, both within your facility, within your laboratory, and with others in your community, both close and far, to make sure that we're not reinventing the wheel all over the place. And then you want to invest in efficiency, including automation and interfacing with lab information systems to really limit the amount of hands-on time that we're using at every stage of the testing process. And most important of all, you want to plan for this and communicate the plan both to people within the laboratory and outside of the laboratory, the caregivers and patients that we serve. And I think that is it. I'm happy to engage in any conversation or questions.
Thank you so much, Dr. Clarke. That was fantastic. I have a question about one of the things that you brought up because it's something I've been wondering, and I know that practice is different throughout Canada and throughout the province even. So you mentioned taking tasks that we may do in the lab and pushing them to other parts of the hospital. So the biggest one for me thinking about is reconstitution at bedside. So we reconstitute everything in our lab here at Vancouver General, but I know it's not the same at all hospitals. Is this something that you guys have moved to in some of your institutions that you've been involved in, or just thoughts on that from you, and happy to bring it to the rest of the community that's here to see what other people do?
Just smiling at, this is a hard sell. I mean, as I said briefly in the slide, of course, we're short of healthcare providers everywhere. So saying we're short of blood bank staff and we can't reconstitute this isn't necessarily met with enthusiasm by the also short nursing staff. So it certainly is a negotiation. There are facilities that have never done this kind of reconstitution, that it's always been the clinical team. So that's easier. I think it's probably a bit case by case. We're trying to do that in an Island Health. And it, like I say, it hasn't always been easy and it is a bit of a negotiation, but if you don't have anybody to do it and you need the fibrinogen in your MHP, it's probably a conversation worth having. I see that some of the chat is saying that quite a few places do have bedside reconstitution.
Yeah, it sounds like in Hamilton, they've moved to bedside reconstitution. And the question from Colleen Chen and Tina, so how are these reconstitution competencies monitored? So Michelle Perry, are you able to comment on that at all? Do you know?
That's a really good question. I would have to check on that. I honestly don't know at the top of my head right now on how we're doing that.
I was just going to say that this strikes me as a blood banker. We got to be in charge of everything question. That might not be our responsibility. Like nurses do reconstitute other drugs. So I suspect that there are competencies elsewhere in their professional domain that cover that. I'm not sure that the transfusion service would have to take that on. I think Jen just answered that actually in the text.
Yeah, thanks so much. I think sometimes we all think of like, this is ours and we do it now, so we're always responsible for every portion of it, but that makes a lot of sense. Eunice, you have your hand up. Do you have a question?
Yeah, I have a potentially loaded question, so we'll see how it goes. So you mentioned Alberta, and one of the advantages I found in working in Alberta is that the health authority is the health authority is not as fragmented as in BC. So I just wanted to know, how much do you think the fragmentation of the health authorities contributes to some of the staffing issues in BC? And is there potentially optimization there as well, with working between the health authorities to try to minimize duplicate testing and optimize things for the benefit of everyone? Potentially loaded question.
Yeah, good question. I mean, there's certainly big advantages to having everybody all in. The disadvantages are that it's really hard in a huge organization to implement sort of locally effective changes. So I think there's pros and cons, and I'll maybe leave whether we ought to be all one or separate aside. I don't think I am qualified to answer that. But I don't think that precludes us from working together. So, I think that we could agree on for rarer tests on localizing them. And, we do that to some extent already, but I think we could think harder about that. Are there things that we don't all need to be doing? And then for those things that we do all need to be doing, I think we do a pretty good job in BC actually of sharing information, at TMAG and bringing back other people's good ideas. We could probably extend that further and, actually use that information to optimize SOPs or processes. So I don't think the organizational umbrella necessarily precludes us from working together more effectively. And when we're solving a problem, the first thing I always want to know is, what is everybody else doing about this? So as you know, Eunice, we've recently had Thamer here as a resident, and was working on a little project while he was on Island Health, and the first thing that we agreed that he should do is ask everybody else in BC what they're doing about cold agglutinins, which is the process that he was working on. So I think we already share ideas. We could probably take that 2 or 3 or 4 steps further and share documents and processes and procedures to a greater extent than we do now, and not just in BC, but maybe in Canada. One of the things that drives me crazy about Canada's healthcare system is that it's 13 of them, and we don't do a really good job of taking everybody's good idea and implementing them everywhere. So maybe the staffing shortages across the country will force us to do that a little more.
Yeah, thanks so much for that question and the answer. And, honestly, because we've recently moved to CST Cerner, which is now 3 different health authorities on the same system. And so we have had to have a lot more collaboration than we've had in the past in terms of order sets, but also now looking at our processes and procedures. I think we're trying to do a better job of harmonizing things when we can and when it makes sense, right?
Yeah.
So I think Claire has a question, but she's having trouble keeping her hand raised. So I will let Claire ask her question. Claire, are you able to unmute? Well, maybe she's having trouble with the buttons too. Oh, she's not able to unmute. Oh, darn. Okay, if you type your question in the chat, Claire, then.
Okay.
Oh, there you go.
Can you hear me? Okay.
Yeah.
Sorry, I'm working from Graham's office today. So I do have one question, and then I'm going to make a point about the reconstitution. Yes, nurses are familiar with reconstituting medications. It's a core competency. One huge difficulty has come up during accreditation and requirements for competency that for nursing that's considered routine work. So that becomes problematic. And the other point I'd like to make is, regardless of who constitutes the product, it's going to take time. And if we're in an area that's small and remote, we're likely looking at a shortage of people at the bedside and a shortage of people in TM. So I mean, I am sure in situations where the decision is made that it will happen at the bedside, that there's collaboration, but the fact of the matter is still going to take X amount of minutes. It's just, where is that happening? And so that was another point. I'm not married to either. Should it be in TM? Should it be at the bedside? But in general, I guess looking at it from the perspective of nursing and saying, if there's a decision that we will, when I say we as in TM, will ask the clinical side to do more, then how do we look at issues of training that staff? Because now nurses are having to take on additional education, and who pays for that education? So if nurses are having to be trained to remove blood from a blood fridge and everything that goes with that, who's responsible for that training, and who's going to pay for it? Because that's what it comes down to in some areas, of somebody being released to go and do this training. And how do we manage that? So I think these are all issues that need to be taken into consideration, because it become the training and maintaining of competency become problematic. Being able to maintain that staff, that education, especially if there's a high turnover of staff within the clinical area, etc.
Yeah, I mean, that's a lot to unpack, but it's a big question. But if there's nobody else to take it out of the fridge and the patient needs it, then you know, I guess that's what you're left with, is that that's why you need a plan. And I think these all have to be sort of locally decided, because it's not going to be, the shortages are not always going to be in the same places in every facility. So I think you really we'll have to be more flexible. It's going to be hard to have a single rule for everyone. And we're really going to have to work together, remembering that, you know, what the goal is to get the right care to the patient.
Oh, absolutely. I'm not saying we shouldn't explore it, but before that, these are things that need to be considered, because the training and maintaining of competency long term has to be taken into account. And you no longer have staff that are within a lab that it's perhaps easier to do that. I know that in Ireland and the UK, it's standard that the blood is in a fridge, and you send a porter, and the porter comes and take it from the fridge. They do not issue direct from TM for red cells like we do here in Canada.
That's been true in rural facilities for years and years and years in Canada. And, you know, really with the advent of vending fridges, that's becoming safer and safer. So,
but with the caveat that you still have to train people and maintain training and competency. So it's just a matter of who are you training?
Right.
And there's a comment in the chat. Some of the upsides of sending the reconstituted products that haven't been reconstituted to the bedside during MHP could prevent wastage. So, you know, sometimes things are ordered during an MHP that won't be used, and if you don't have the capacity throughout your hospital to use that within the expiry window, then you'd have to expire it. So, okay, Tyler, you have a question?
Yeah. I was wondering, Gwen, if I could ask you something kind of that, you know, your talk mostly focused on practical issues. I think one of the issues that's been hard for us lately, and I think this has been going on really since the pandemic, is morale issues. Do you have any suggestions or things that you found helpful in terms of boosting morale in the lab?
So it's funny, I got asked that question when I first gave this talk at ISBT. Somebody said, how could we keep people engaged and interested? And I said, you should send them to ISBT meetings. So I could start with that. I think when I look at my transfusion medicine technical colleagues from when I started my career to the present, one thing that I see that's different is that there's less engagement professionally in terms of wanting to attend continuing education events, like especially ones that you have to pay for, where you have to go somewhere to go to a conference. I love going to conferences. CSTM is like my favorite thing in the whole year, including my vacations. So somehow, inspiring that interest and enthusiasm for collaboration with colleagues. I don't know how to do that exactly, but I think everybody is feeling like they're just in the trenches, working day after day, having too much to do. So, I think collectively, for all of us that work in laboratories, thinking of ways to remain engaged. And I think one way to remain engaged is to engage people in thinking about how to make things better. So we always do what we've always done, and we're short of people, but we're still trying to do things the same way. So if we could all try and wrap our heads around adjusting the way we do things to the new number of people that we have, or to the new ways of doing things, I think that might help. Like, it gives people some agency in not thinking that they have to be done this way. How could we adjust this? There's barriers, but how could we go around those barriers to make it better? How could we, and making that conversation involve our whole staff and not just the lab leadership, I think would be helpful in engaging them more generally in their workplace, and then maybe on a larger scale, more generally in the profession. So I think that's a big part of it, is that we've developed leadership and management structures that are a bit exclusive. And I think we've got to get away from that, both because we don't also have enough leaders, but also because it's not good for anybody working to not have the input. And it's not the same as saying we did a focus group where we asked for input at a meeting. Getting people actually engaged in those activities is really critical. And, I can hear the naysayers saying, but then they have to come off the bench in order to do that, and we don't have time for that. But I think we just have to be a bit creative in how we approach problem solving and try and really engage the people that are doing the work in as to how it could be made better.
Yeah, and I guess make sure those engagement initiatives are kind of efficient, so everyone feels like they're engaged, like they're not. This isn't just a thing where we're pretending to listen, but it's actually like an engaged, active process.
Yeah, and that often happens in a crisis. We're not going to have any staff. We're going to have to reorganize. People really come together and do that. So if we could do it without the crisis, that would be even better. We could say we want to, we have some efficiency goals here that we want to be able to run this lab with only 3 people instead of 2, not because we're firing anybody, but because we don't have enough people to fill the shifts. How could we do that? So, engage people in thinking about how we could do things differently in order to successfully function.
Thanks, Gwen.
Nick, you have a question?
Yeah, I do. Hi, Dr. Clarke. Thanks for the talk. Really enjoyed it. Sort of along the lines of what Tyler asked about morale, but I've noticed like tech staff have been getting younger and younger, and there seems to be a lot of loss of that sort of older generation to sort of mentor the younger staff, and especially in the area like TM where if you're alone, you're trying to manage an MHP and stuff like that, it can get quite hairy. Like, do you have any thoughts on how to help these younger staff members deal with these situations better? Maybe not just in TM, but in the lab in general.
Yeah, I think you're right. I laughed when you said that, because the older you get, the younger everybody seems. So I assure you, I agree. The staff are getting younger and younger. But I think there is actually I think there's stats around that. Like when the technologist workforce really declined in the 90s and early 2000s, that meant that a whole cohort left the profession, and we're sort of missing that senior group that would have been mentors to those that are coming in. And then we're at a time when we're trying to hire, and so we have a lot of sort of new young people starting. So that is hard. I actually think that as hematopathologists, as medical staff in the lab, that we have a role here. I often I'm on call this week, and a certain number of the calls that I get I sort of think, oh, I wish I wasn't getting called about that. But when I'm thinking rationally about it, I think that the role of the medical staff in managing these calls is really just not necessarily to do anything, but to support the technologists in their decision making. And I think that that will be even more important as we have a cohort of technologists without supervisory technologist support. So I think real engagement of laboratory physicians in the way that the lab runs is important. And knowing the procedures and knowing how to support the staff, certainly in a case like an MHP, I think hopefully we're helping the patient and the clinical team, but we're also really helping our laboratory team in managing that MHP. So I think that's part of it. And then, the other thing I think we come back to is just really good planning, so that even somebody that's pretty junior has very easy to follow, simple instructions as to how to manage in an MHP setting. So it comes back full circle to just that efficient practice with good processes and procedures that they can refer to easily. And then adequate support, if not from technologists, then from their laboratory physicians.
Thanks. Yeah. Michelle?
Yeah, I think that those are all great points, and kind of along the same vein, like we've had a lot of shortages in Fraser, even at some of our big hub sites. And I'm not saying that this is the possible in every scenario, but we've had some senior leadership people even step up and do some of the bench shifts, right? And I think that that's part of the mentoring. If your senior leadership can actually step up and demonstrate that they're willing to put out, and then they're working side by side with some of the junior ones, right? There's a lot of learning that can occur, even if it's just a few shifts. And it's actually good for senior leadership to kind of go back to the basics and think, are some of the processes that we've implemented, do they actually work when you're actually working at the bench? So I don't know, that's every little small thing I think can make a difference for the morale. And yeah.
Yeah, that's an interesting example, Michelle. I spent a lot of my early career doing lab inspections in small rural labs, and one of the interesting things I'm seeing as I look at shortages in larger facilities now is some of the solutions that have been in place in small places for years are coming back to big places, and that's a good example of it. So, there would be very few small labs where the supervisory staff didn't also have a role on the bench, but in larger labs, those become more remote positions. You're supervising from afar. And now what you're describing is kind of coming back to the basics, where there might be some role for supervisors or managers that actually work. And that's really interesting, and a lesson maybe we can take from smaller labs that were having to use their resources differently all along.
I think it was just a call out even. It's either that or we were going to have to close potentially TM at a big hub site, which is just not possible. So I think it says a lot to some of the junior staffs or just the staff in general when the senior leadership is able to we will walk in there and make sure that the ship is kept afloat.
Yeah.
I think it helped. It did. It sets a good tone.
Yeah. I did also like some of your comments, Dr. Clarke, about like alternative options, like getting clerical staff to answer the phones. Answering the phones has become a very large problem that our technologists have told us about, because with our new Cerner implementation, sometimes the wards are saying, is my blood ready? Is my blood ready? Like constantly, when they can check online, but sometimes it's faster for them to just call down. So one of the issues that we talked about is there are some areas of the hospital that actually do need to talk to the blood ordering technologist like immediately. So has anybody implemented a system where there's, two numbers, one for non-urgent and one for like the OR needs blood immediately to order blood?
I don't know if anybody from APL is on the call, but for years, Calgary had a really good phone system. Their labs were silent. And I'm not sure if there's anybody here that could speak to that. They had, so basically, I think they were technologists for answering the phones, but not kind of in the lab, and then we're triaging the calls appropriately. So I think there's ways to do that. And that's a huge distraction, when you're trying to do something and the phone, and you're constantly picking up the phone. We all know that from being on call when you're trying to do that 2 or 3 times.
Yeah, but if there was an urgent number that, you only gave out to OR, ER, or whoever needs it, and then like something that's more connected to either a clerical staff or an answering machine, like making them go through all the processes. Like
Those are not my favorite.
no, but at least, if did you check Cerner? Yeah. Any other questions?
Oh, there's an interesting comment there from St. Paul's. The bat phone.
Oh my goodness, yes, that's amazing.
A secret communication channel.
We did try Voicera at one point, but yeah, Voicera, it wasn't as effective, but that our clinical teams are not constantly wearing the Voicera. Like I know at some hospitals, that's what they use to communicate. So this would be, a Voicera only for MHP. So it would need to be turned on and get ready. So it's a little bit less effective than if everybody was always using Voicera. Any more questions or comments before we wrap up for today? Oh, Michelle, go ahead.
Oh, just really quickly, in terms of offloading responsibilities for techs, like, how everything, it's especially at some of the smaller sites, and this may be more specific to Fraser because we procure basically all of the marrows, and the pathologists do it. But so we've offloaded some of the tech-specific responsibilities that are not tech-specific, sorry, I meant, for the bone marrows, and we've got some MLAs doing some of that, but then that means that you free up some of your techs that are actually maybe heme that can maybe then go cross-cover TM. So, everything might have a downstream effect. So we are offloading some of, like looking critically, what absolutely needs to be done by a technologist and what could be offloaded to an MLA to free up your tech who can maybe then cross-cover. So anyways, because the priority is usually TM is more critical and acute. Yeah.
Yeah, we were just talking about that here yesterday as well, as really looking at the tasks and saying which one of these need a technologist to do them. And as you say, it might have downstream effects even in other departments. So I think it's important to think broadly, about the lab as a whole and how you could combine things.
Yeah, I agree. Claire?
Gwen, I was just wondering if you could talk a little bit more about sort of using lean approach and removing redundancies, because I know myself that when I've come into TM and we had a process for a cord blood, and when we started to look at it, it wasn't very smart, and so we started to make some changes. Now that was really about turnaround times, really, but it's just even knowing how to identify what might need to be changed, and you said like sometimes it's when a new piece of equipment comes in that kind of triggers it. But is there any other suggestions you might have to prompt to even start to look to look at the ways of finding
I'll bet the technology
improvement opportunity. The technologists know, yeah.
No, if you go in the lab and say, what processes are we doing that aren't working, you'll get a lot of suggestions. And they're just things that are cumbersome, and it's awkward to start on a project like this because you have to do a bunch of stuff, and who's going to do this, but it does pay dividends in the end if you just embark. If you every year, every 6 months, you pick one thing that's a pain point and try and fix it, try and streamline it, try and make it smoother, maybe get rid of it altogether. Though I think you could just kind of pick away at the things that are problematic and really make things run more smoothly. But I'll bet everybody, we have a joke here about our whiteboard in transfusion of all the things we want to get done. So, I'm sure everybody that works in your facility has a list in their head of things they'd like to fix. And it's just a matter of triaging those and picking one to get started with.
Thanks.
Yeah, we have weekly huddles, and we are very fortunate to have some pretty vocal staff about what the pain points are. So the hard part is fixing them, especially with enterprise solutions across 3 sites that that we're, you know, stuck with for Cerner. So
Yeah, I
it
mean,
does become challenging.
challenging. You just have to be a bit creative about, okay, what can we modify here that isn't going to impact the computer, for example, or
Yeah, exactly. Any other last minute questions? Well, thank you so much, Dr. Clarke, for your wonderful presentation. As I mentioned, at the end, there'll be a link that you can copy and paste for the evaluation and attendance tracking. Thank you to everybody from BC and throughout Canada who is now attending these. And we hope to see you next time.
thanks, Krista. Thanks, everyone.
Bye.